Hello, my name is Michael Lago, and I'm a current SRNA at the University of Miami. And I'm going to be explaining to you this project I am implementing at North Shore Medical Center. The project entails the utilization of precedex as a neuraxial anesthetic adjunct. A quick introduction. We are all aware of how many Americans die every year from fentanyl and other opioid related overdoses. Even though it's been many years, we continue to have the numbers increasing. The CDC put out the data for 2021. It was over 100,000, and the numbers continue to climb. They estimate about 45 patients per day die from prescription overdoses, and that's excluding fentanyls. In a study that was conducted by a coroner's office, they traced back prescriptions and found that although primary care physicians had the highest number of overdosed prescriptions, anesthesiology patients who received prescriptions from some kind of a post operative care setting had a high number for the small amount of prescriptions that were being provided to patients. So even though it's a small percentage of providers, they did have a high likelihood of being capable of causing a overdose. Also, patients who are opioid naive are capable of developing opioid dependence. A study that was conducted by the CDC found after 1 day of opioid use, a patient has a 6% chance of still being on opioids a year later. And if they're on 8 days of opioids, they have more than double, a 13.5% chance of continuing on opioid use, and that would be opioid dependency already. Orthopedic surgeries, conducting lower extremity orthopedic surgery specifically, are some of the most common surgeries, and we do prescribe, usually by the surgeon's office, prescriptions for opioids. So for that reason, I'm going to just be focusing on that for my implementation project, just to provide some scope. Some background about neuraxial technique and adjuncts. Many medications over the years showed a lot of promise. However, in research, animal studies, many of these different medications caused nerve injury or didn't provide any true benefit over being just the adjunct versus replacement. In many hospitals, a lot of providers like to add a little bit of fentanyl to their local anesthetic for their spinal neuraxial techniques, and it ended up becoming the most commonly used according to the literature. However, more recent literature has been published showing that precedex is a superior adjunct. It's found to have prolonged the duration of block when it's just the block with local anesthetic by greater than 100 minutes, and it has prolonged patient pain by over an hour when compared to fentanyl. So not only is it superior to just local alone, it is superior to when fentanyl, which is the most commonly used adjunct. So this is just a quick protocol, kind of like a decision tree that I helped to develop. Just discusses how spinal anesthesia is very commonly used for orthopedic surgeries as the scope. The literature shows that many other procedures can be done successfully, but for the sake of this project, we'll just focus on the orthopedics. Dexmedetomidine, which is precedex, functions on the alpha 2, providing analgesia and sedation. The research has found that just 5 micrograms of precedex is capable of prolonging those 100 minutes and greater than 60 minutes, even when compared to the most commonly used adjunct fentanyl. The contraindications for Intrathecal precedex is very similar to that of IV. The decision tree here to the left side of the screen. Any of the reasons on the left would be reasons not to administer. So if the patient has any contraindications, direct contraindication being allergy, or if they have any kind of aortic stenosis, chronic hypertension that is uncontrolled, if the patient's having a short procedure, do you truly need to have this patient with greater than 100 minutes of block duration? Nowadays, we're trying to get patients up and mobile as quickly as possible. If you can just do a supplemental block in the PACU or at the end of case, maybe adding the precedex is not going to be beneficial. And the last reason would be if the patient's already taking some kind of an alpha blocker. Maybe they take clonidine PO or another type of heart rate reducing agent, and they are on the lower end of the spectrum. This medication, like I said, does have very similar effect in the spinal canal as it does in the IV. So if a patient would not be someone you would give it as an infusion, same would carry over. And also, if this is a patient that should not have a spinal to begin with, then neuraxial technique plus neuraxial with this adjunct would also just completely be out of the question. So if the patient would benefit from a prolonged duration of block, maybe they're doing both knees, maybe they're doing a revision, just the 5 mics of precedex, you can go down, this is the decision tree on the right hand side, would prolong, and then it would be okay to administer if there's benefits with no contraindications. And touching on some of the side effects, like I have mentioned, it's very similar to that of being administered intravenously. The literature showed nausea, vomiting was the number one reported symptom by patients. Very few patients had an additional bradycardia and hypotension that required treatment. Most of the literature showed that there was a decrease that eventually came back up on its own without requiring treatment that was set by the parameters of the study. Treatment would be the same as if you were giving precedex IV, except you can't stop it. It's already administered. So the treatment would be to increase your SVR, and you want to increase your heart rate. Small increases of side effects were reported during the studies when compared to just the local anesthetic alone, because we are introducing an agent that has its own side effect profile. And for the evaluation plan, upon completion of reviewing the literature with the actual protocol on the Word document, as well as this PowerPoint, if you could please fill out the survey. It's just a few questions about demographics and a couple questions regarding the educational materials that were created along with the protocol. Thank you very much for your time, and these are some of the references that are provided during this PowerPoint.